Welcome to this Australian Doctors Federation Let's Talk Medicine podcast entitled Bulk Billing First Do No Harm. I'm Dr. Chris Davis. In this podcast, three eminent general practitioners explain how their ability to efficiently and sustainably provide vital patient services is being impeded. In turn, this translates into less efficient and more expensive downstream healthcare. Healthy Australians are vital for a productive Australia. To help achieve this, general practitioners must again be empowered to apply their professional expertise in accordance with their professional and ethical obligations. The alternative of commodified, stultified, fragmented, diminished and demoralised general practice limits our well-being and so compounds our economic malaise. Recent polls indicate around 2/3 of Australians believe our nation is headed in the wrong direction. This podcast reminds us just why, but more importantly, offers solutions. We go now to Dr. Aniello Iannuzzi, Chair of the Australian Doctors Federation.
Welcome to another episode of Let's Talk Medicine, and we're staying on the topic of the GP crisis. It's now about 6 months since the major overhaul of general practice in November 2025. We're now in June 2026. So just over 6 months since those overhauls. And where are we up to now in general practice? And also we're going to touch on a few things that affect other specialties. My guests are Professor Karen Price, current chair of the AMA CGP and former president of the RACGP, and Professor Mukesh Haikerwal, former AMA president and former chair of the World Medical Association. Welcome to both of you. Karen, we'd like to start with you. We're 6 months into what was meant to be a renaissance of general practice. Where do you see things at the moment?
The current government is now facing a mammoth loss of trust with the medical profession and equally with the electorate. They've broken the social contract. They've promised lots, but the implementation has been really poor. We've got the private health insurers talking about issues. We've got the non-GP medical specialist being under attack for charging gaps, which to me is an admission of failure that the public hospital system is not working. And then we've got GPs who are being burdened with all sorts of complex chronic disease, aged care, all of the complex hard stuff, while we have the tricksters and the flicksters who are managing this huge amount of tick and flick medicine because they've got a doorway into the minister's office with a big wad of lobbying money. So it's a pretty awful situation, and there certainly doesn't seem to be a vision for reform. It just seems to be focused on votes and reputation of people who live by reputation, and that's absolutely no way to run a health system. We were promised big promises that this current government, like other governments, would work with the medical profession. In my observation, the leadership of all the organisations are reasonable people who understand there are challenges and calls on things that, sometimes you need to modify a little bit, but happy to work with. We've had consultation after consultation, which Mukesh has seen before me, and we've just got people in Canberra sitting on their hands.
Mukesh?
There's been an increase in the level of bulk billing because of the new incentives. But in my view, the government is shooting itself in the foot because the first promise of indexation has already fallen at the first hurdle by not even meeting normal inflation, forgetting about health inflation. And alongside that, the increasing levels of bureaucracy, which is going to make it extremely difficult to continue to do things like telehealth or aged care or home visits because of the cumbersome process that's now expected to sign off for the assignment of benefits. So it means then that people who've converted to 100% bulk billing with the hope that the PIP incentive will be enough to see them, will suddenly see all that go. If one single bill has to be privately billed, there's been no regaining the trust, and the fine words are not matched with fine actions. And siphoning people away from general practices to urgent care clinics, towards other providers of health services, is really leaving general practice bereft.
Thank you. So there are two major components to this. One is a trust issue, and they've broken trust, not only with the profession but the public. And there's also what seems to be a major productivity problem here as well with the compliance costs of running practices. So let's just break down the trust bit initially. We were promised, as you said, that patients would be needing nothing more than a Medicare card, and somehow there'd be a flourishing of bulk billing. I think there's been a little bit of an uplift, but from what I'm seeing, it hasn't been a massive increase in bulk billing. A lot of patients are still saying in many places you can't get a bulk billed visit. The things that count there are your item 23s and 36s that relate to normal consultations. Of course, you'll get bulk billing for your care plans and pathology tests and a lot of your radiology a lot of the time, but we're not talking about that. Those who signed up to the bulk billing incentive, who were made to put those green and gold stickers at the front of their surgery and make it look like they're government clinics when they're not government clinics, have now, I think, been given a Trojan horse because of the compliance costs of having to go back to signing for every episode. And that's going to cause havoc at front desks. It's going to cause major expense to practices if it means that they're going to go to an electronic signature storing method, or otherwise they're going to need to go back to pen and paper and ink, and that's going to cost a massive amount in staff time, paper, ink and storage, possibly security for some practices as well. I think productivity is a problem we have right across the health sector, if not the whole economy at the moment. And in an age where we've been encouraged to do telehealth and generate those efficiencies that have occurred since COVID, it seems like a massive step backwards to see the government wanting patients and doctors to go back to a signature for every episode. There are certainly ways the government could be enforcing and encouraging compliance. They've got the PSR, they've got Medicare itself, who have massive powers to audit. That's what they need to do. They need to be policing the system better rather than creating hindrances to those trying to do the right thing. So there we are. And the indexation, of course, as you mentioned, Mukesh, what a letdown, really. We have a cost of living crisis, we have inflation, we have high interest rates, and it seems like everybody else is allowed to ask for higher pay, but not doctors. And that's not only GPs, it's the whole Medicare system that hasn't been indexed properly. So other specialties, apart from GP, are impacted as well. And these compliance measures that relate to signing for every episode don't only apply to GPs, they also apply to those specialists who bulk bill, like a lot of the outpatients clinics, outreach clinics. So this is going to have a broader impact than what meets the eye. Karen, you're the head of the AMA CGP and you've been the head of the college. Where do you think the college and the AMA should be moving here, and what do you think they can do to help the public and help the profession to resolve this issue?
We need to go on a hearts and minds tour with our patients. We need to start talking about what's been taken away from them, and we need to be proud of our quality. We've got to maintain our professionalism. We've also got to give hope to our colleagues that profession's worth saving. A good, strong primary care sector and a whole of system that works. So mental health, for instance, is abysmal. You know, we've had the aged care crisis, but it doesn't seem to have resolved, and it's only going to get worse. So people are rightly concerned about these things, and all we get is another shiny announcement that we've got a XYZ disease new clinic, as if that's going to solve things. Professor Chris Hogan always talks about the health literacy of our population, but I think there's a combination of health literacy and financial literacy that we need to really start talking about. Now, our practices come in contact with every single person in Australia pretty much at least once a year. We've got an enormous reach into the population, and I think that's where we have to go. We have to go start winning hearts and minds, and it's slow, hard slog work. We've got to talk about the fact that Medicare is their resources, because what's happened is the government has very successfully wrestled that transaction off us. The transaction was always between us and the patient. That's where the contract is of delivering care. That's where the patient can hold me or any of us accountable for what we've done, both financially in the billing and for the service that they've received. Now we have that many other people in the room, metaphorically, and you even see some doctors talking about this like the government's employing them. And by that kind of very subtle shift in language and idea, we can very easily lose our profession. So I think there's two things. We need to really make sure people understand this is a profession. It must be independent of government, because we have to hold governments to account on behalf of our patients. That's one of our professional roles. And if we are beholden to government, or we're so scared to say anything that, we're going to be somehow whacked over the head, that's not good for our colleges. It's not good for the AMA to be living in fear of the government shutting the door. I wouldn't be afraid of that, because I'd go straight to the patients. I'd go straight to the electorate and start talking about what's not being delivered.
The doctor-patient relationship is being further diluted by all of this, and that's one of the main reasons, if not the main reason, why the Australian Doctors Thing continues. This recording is done in mid-June for those of you who listen to it later. When these changes come in on the 1st of July, where I see things breaking, number one will be the aged care. What they're proposing now, that we have to chase a signature for every single episode of care, is just going to be totally unworkable. Our front desks aren't going to be able to do it. The GP visit aged care facilities, well, by nature, it's not at their clinics, so how are their reception staff going to chase the admin? It's very difficult. Relatives are often nowhere to be found, and Medicare doesn't permit the nurses at the aged care facilities to sign on behalf of the patient. A lot of the patients, even if you can get them to sign, have no capacity to be signing anyway. In rural areas, this is particularly a problem. I have 50, 60 aged care patients that I look after, and for most of them, the next of kin literally live hundreds of kilometres away. How am I going to find these people to sign every time I see a patient? A lot of the time, the things that you do for aged care patients are things that people don't even realise you're doing, like scripts and medication reviews, referrals to physios, referrals to podiatrists. So it's really a point that it's going to pop, and I think what a lot of doctors are going to be forced to do is send patients a bill at the end of the month, just like the pharmacy does, and say, hey, I've done X number of services for you, here's $300 or $400 bill. It's going to send families into tilt. It's going to send the aged care sector managers into tilt, and politicians are going to get a lot of invective from their patients. Angry relatives are going to be right into their members of parliament very quickly. Worse than that, a lot of doctors are going to say, I don't know who the relative is, so I send the patient to ED. There's only so much GPs can take.
Yeah, sorry.
Another breaking point is going to be in rural areas. Bureaucrats in Canberra may not understand this, but a lot of patients in rural areas don't have mobile phone coverage where they live or even where they work, and some of them don't have internet, and the only thing they may have is a landline. And if you're doing a telehealth consult to save that patient travelling many kilometres, especially with petrol at $2 and $3 a litre, to see you, how are you going to get a signature of that patient? Thanks. It's going to lead to a drop in bulk billing and further betrayal of these practices that have signed up to the bulk billing incentive, and now they're going to think, well, heck, what do we do now? We either have to just drop a lot of nursing home visits and telehealth visits because we can never get paid, and as Mukesh, you said correctly, you trip up on even one and the whole practice loses 12.5% of their income. Who's going to take that risk? I just wonder how state health ministers are going to react to this latest round of changes. The stress on their EDs, particularly in rural areas, is going to be palpable. It's going to lead to cost blowouts, and going back to that example of a nursing home patient, not only does that patient go to ED, inevitably that patient's going to be admitted, because getting the patient back to the nursing home becomes a challenge. You can't just click your fingers and expect an ambulance or someone to come and collect that patient. So all of a sudden, a visit that may have cost the taxpayer $50 or $60, maybe even $100, say, for a GP to visit in a nursing home and sort out a simple problem, becomes an ambulance transfer, ED presentation, 2 or 3 day admission, discharge and whatever. So all of a sudden a $100 problem becomes a $10,000 problem. Now, you only have to do that a few times, and the state health ministers are going to be ringing alarm bells. So state health ministers need to be tapping Mark Butler on the shoulder and saying, Mark, you might have to go back to your bureaucrats and have a look at these changes because productivity is going to be severely impaired here. It's just so counter to everything else that's happening in the modern economy. And the thing is, what does it mean for a patient to sign an assignment of benefit form if they don't even know what they're signing? So if they're really serious about wanting to get compliance correct, they need to be auditing better. That's all there is to it. That may be the only real solution for practices to protect themselves, which patients aren't going to want to hear. But ultimately, as you've both said, the Medicare rebate is the patient's rebate, and the transaction is really between a doctor and a patient.
Exactly.
The way to keep it really clean is to charge the patient, and then it's between the patient and Medicare. The government has distorted that to the point where people think that somehow the rebate is the doctor's and the doctor works for the government, and that's really a dangerous place to be. And that's where I think myself, the colleges and the AMA should be doing a lot more to educate, as you said, Karen, hearts and minds. One other point before we finish is that urgent care clinics are now going to be a permanent part of the landscape, and they're going to insert themselves into what they consider to be areas of marketplace failure. So the government will bankroll clinics in places where they feel the bulk billing rates are too low. Who, as a young doctor, is going to want to set up a private practice when you've got the capital gains tax changes, the payroll tax problems, and now the threat that the government will come and set up in direct competition to you if they don't like your billing style? It's a crazy scenario, and it's little wonder that only about 1 in 10 young doctors want to be general practitioners anymore.
That's a tragedy.
Yeah, I often see double and triple handling from UCCs. They go to UCC to ED and then finally back to the GP to get sorted out properly.
And that's just a tip of the iceberg of healthcare, because anyone who believes that urgent care, acute care is going to solve our healthcare issues, our patient demographic issues, chronic disease management, that's what's chugging the hospitals, that's what's causing a lot of challenge within the system, and they're the people who are not getting access and not getting care. Costing, I don't want to look at someone's healthcare costing, it sounds a bit immoral, but, it is costing if it's not treated properly. This sacred contract between a doctor and their patient, which used to operate, is being totally ignored and undermined as if it's something that we should get rid of and that we can just commoditise healthcare by building another building dedicated to a single point of difference, whether it's migraine clinic or a mental health clinic or a women's pain clinic. And all the advertising that goes around that is it denigrates the care that good doctors have provided for decades, subsidising out of their own pockets often people who can't always afford the full cost of care. So I'm really disgusted by the change in our health system by government and the bureaucrats to treat dedicated professionals so cynically is a big societal wrong, and it will be unfortunately the patients who suffer.
Bulk billing is certainly not a measure of quality, it's only a measure of cost and perhaps access. I'd like to thank both of you for participating in this latest episode of the GP Crisis. I'm sure we'll reconvene in a few months' time and see where things are up to, and of course, we'd also like to cover some other topics outside of general practice, and we will do so in the next few months as well. So for those of you who have enjoyed this episode of Let's Talk Medicine, I encourage you to follow us on Spotify, on YouTube, on LinkedIn, Facebook. And for those of you who can, consider joining the Australian Doctors Federation. We don't charge a lot to keep our administration going and to do projects like this. The doctor-patient relationship remains the most important thing, and we defend it at all costs, and we have to remember that we're the patient's doctor and not the government's doctor. On that note, I thank you all and look forward to seeing you again sometime soon.